Okay, so we discussed about the definition of epilepsy, then we discussed something about the causes. Based on the age, how to decide what may be the most important cause, what are the investigation to send, and how to approach a patient with the epilepsy. So in this part now we'll be discussing about some stroke mimics and how to identify them, and about basically the treatment of seizures and some special scenarios. Okay, let Dr. Aravind continue.
Uh, there are a set of differential diagnoses of seizures, most commonly syncopes, all forms of syncopes like vasovagal syncope, cardiac arrhythmias, syncope associated with valvular heart disease, cardiac failure, orthostatic hypotension, and psychological disorders like even psychogenic seizures, hyperventilation, panic attack, metabolic disturbances like alcoholic blackouts, delirium tremens, hypoglycemia, hypoxia, use of psychoactive drugs like hallucinogens, migraine, confusional migraine, basilar migraine, transient ischemic attack, basilar artery TIA, and sleep disorders like narcolepsy, cataplexy, benign sleep myoclonus, and certain movement disorders like tics, non-epileptic myoclonus, paroxysmal choreoathetosis, all should be a close differentials for seizures. In children, breath holding spells, migraine with recurrent abdominal pain and cyclic vomiting, benign paroxysmal vertigo, apnea, night terrors, sleep waking should all be a differential, considered as differential diagnosis. So, clinically, how to differentiate between seizure and syncope is that in seizure, there is no immediate precipitating factors are not present. In syncope, it is most commonly associated with the precipitating factors like emotional stress or Valsalva maneuver or orthostatic hypotension or cardiac etiology. In seizures, there can be premonitory symptoms like premonitory symptoms can be
Hello.
Sir, shall I continue?
Yes, continue. Screen is not visible. I think you can share and
Now visible, audible. Okay.
now we are audible, it's not visible. I think you have to share again.
Um, visible.
Yes, now it's visible. I think you can start from the slide itself. Difference between seizure and syncope. Connection went from
Uh,
there only.
so clinically, based on the presence of immediate precipitating factors, premonitory symptoms, what was the posture at the onset, how quickly they transitioned into unconsciousness, what was the duration of unconsciousness, what was the duration of tonic-clonic movements, what was the facial appearance during the event, and after the event, how was the patient, was there aching of muscles, any tongue bite, any bowel or bladder incontinence, or headache. Based on these features, we can make a difference between seizures and syncope. In seizure, it is the precipitating factors may not be present all the time. Premonitory symptoms may or may not be present. The posture can be variable. The transition to unconsciousness is often immediate. Duration of unconsciousness is in minutes. Duration of the tonic or clonic movements is usually 30 to 60 seconds. The facial appearance, there can be cyanosis, frothing from the mouth during the onset. The post-ictal, there can be confusions and disorientations. There will be aching of muscles due to the tonic-clonic movements. There will be occasionally associated with biting of tongues and bowel or bladder incontinence and headaches. Whereas in syncope, usually there will be a precipitating factor like an emotional stress or valsalva maneuver or orthostatic hypotension or cardiac etiologies. Premonitory symptoms like tiredness, nausea, tunneling of visions can be there. Usually they are erect when the symptoms occur. It gradually happens over seconds. The duration of unconsciousness is usually in seconds, and any movements, if at all, it lasts more than, it is never more than 15 seconds. There can be pallor at the time of event, and the confusion or a disorientation usually lasts for less than 5 minutes. Sometimes there can be aching of muscles, but biting of tongue, headache, or incontinence are somewhat less common in syncope than seizures.
Tongue bite is actually a lateral tongue bite. Anterior tongue bite cannot be taken as tongue bite. Lateral tongue bite should be taken as tongue bite. And syncope can
Yes.
never be more than 15 seconds, whereas seizure will last more than 15 seconds. So again, this is also a very important slide because there have been case reports where syncope was wrongly treated as seizure for 17 years. There are case reports. Okay, so this table is very important. Continue.
Moving on to psychogenic seizures, they are non-epileptic behaviors basically. They are part of the conversion reaction. Behaviors include side-to-side turning of the head, ictal eye closure, asymmetric large amplitude shaking movements of the limbs, twitching of all the four extremities without loss of consciousness, and pelvic thrusting from the bed. It usually lasts longer than usual seizure. It may wax and wane over the minutes to hours, but it may coexist with epilepsy. Another important point. Whenever doubtful, we can go with video EEG monitoring. Most generalized seizures and some focal seizures are accompanied by a rise in serum prolactin during the immediate 30-minute post-ictal period. Whereas psychogenic seizures are not, though this is not always reliable because baseline prolactin levels are rarely available and certain medications can elevate prolactin levels. That is, post seizures, that can be transient rise in serum prolactin, but in psychogenic seizures, it is not so. But most of the time, we don't have any baseline values to differentiate. So it is not always, and there are many other medications that can elevate prolactin levels. So it's not always the method to go to differentiate between true and psychogenic seizures. Moving on to treatment. Most of the treatments which I'm going to discuss in the further slides are from NICE guidelines 2022. So consider starting treatment after an first unprovoked seizure if any of the following, like if you find on examination there is signs of neurological deficit, or EEG shows unequivocal epileptic activities, or if you suspect there is a risk of further seizures and the risk is unacceptable, you decide on starting anti-seizure medications, or you pick up a structural abnormality in brain imaging, you can go with anti-seizure medications after the first unprovoked seizure event. So all treatment anti-seizure medications should be individualized. Always go with the monotherapy whenever possible. Uh, uh, they prefer to go start with a lower dose and increase slowly. This is somewhat controversial. This mostly applies to the second agent or adjunctive medication whichever we are starting. So despite an optimal dose of the first line anti-seizure medication, if the patient is developing seizures, it is always best to uh, review the diagnosis of epilepsy which we are treating. And in case if the first line monotherapy is unsuccessful and the epilepsy diagnosis remains confirmed, so we can try either monotherapy with another anti-seizure medications, which we have to make a transition over a period of time. That is, either you can go with another monotherapy or you can have an adjunctive therapy to the first anti-seizure medication. In case you are decided to go with another anti-seizure medications, the dose of the second medicine should be increased slowly over a period of time while maintaining the first anti-seizure medication dose. And if the seizure second line medicine is successful, we have to slowly taper off the dose of the first medication. And if the second line medicine is also unsuccessful, and then you find no added benefit to the drug, we can slowly taper off the dose of the second medicine and you can consider another drug. And another method is if monotherapy is unsuccessful, we can go with add-on treatments. If in trials of add-on treatment does not result in reduction of seizures, then it has to be the regimen is the clinician's choice, but there should be best balance between the effectiveness of the regimen and tolerability of the side effects. That is, we should not cause more harm by controlling the seizures. Both should be balanced. Our main outcome for anti-seizure medication is that if the epilepsy or seizure can be controlled, that no further seizures is occurring, like seizure freedom, or in certain complex seizure syndromes where our aim can be only seizure reduction. And uh, there is a concept called a time to treatment withdrawal or time to treatment failure. That is, we withdraw anti-seizure medication due to any reason, be that lack of efficacy or adverse events or any other reason, should also be our outcome while treating a patient with seizures. And certain other measures which I will be discussing in further slides, like ketogenic diet for patients with SEL2A1 gene mutation can be helpful, which encodes for a GLUT1 transporter, and ALDH7A1 gene, which encodes for anticolin, which is involved in the breakdown of lysine, which can cause alterations in the pyridoxine metabolism that are reversed by treatment with pyridoxine. So, in patients with pyridoxine dependent epilepsy, supplementing pyridoxine can be beneficial. So, these are all some dietary advices which I will be covering in further slides. Moving on to anti-seizure medications. These are based on the all meta-analysis of available randomized controlled trials. So they suggest for focal seizures, the first line agent can be lamotrigine or levetiracetam. Alternatives can be carbamazepine, oxcarbazepine, or zonisamide. For a generalized tonic-clonic seizure, the well-studied drug with which shows superior benefit is sodium valproate. Alternative can be lamotrigine and levetiracetam. This combination of lamotrigine and levetiracetam uh, uh, can be like it often repeats in many of the treatment regimens. For focal seizures, as an add-on therapy, Again, if you are going with the lamotrigine, levetiracetam can be added as an add-on treatment or a second-line agent. Like that, we have first-line add-on therapy for focal seizures. Both the lamotrigine, levetiracetam, other drugs like carbamazepine, oxcarbazepine, zonisamide, lacosamide, and topiramate can be chosen. Second-line agents like brivaracetam, carbamazepine, perampanel, and pregabalin can be used. For generalized tonic-clonic seizures, again, despite treating them with a single agent like either sodium valproate or other drugs like lamotrigine or levetiracetam, the other drug, whichever the drug we are not choosing from these three, can be added as an add-on therapy. They all come under MATE, clobazam can be used. Second line agents, brivaracetam, phenobarbital, primidone, and zonisamide can be used. So there are certain drugs which should be avoided in case of coexistence of absence or myoclonic seizures, because in some studies they have found out the following drugs can exacerbate absence or myoclonic seizures. This includes carbamazepine, oxcarbazepine, phenytoin, gabapentin, pregabalin, tiagabin, and vigabatrin. Coming to pregnancy and lactation, the safest, well-studied drug are among the anti-seizure medications are levetiracetam and lamotrigine. In breastfeeding, generally the amount of drug that is excreted in the breastfeed milk is very low. So we should not always breastfeeding should be encouraged, though the patient is on anti-seizure medications. Some drugs are associated with major congenital malformations like phenytoin, phenobarbital, sodium valproate, carbamazepine, and recently topiramate and pregabalin. Some drugs are associated with neurodevelopmental disorders like carbamazepine, though the evidence is limited. And some reproductive toxin anti-seizure medications are carbamazepine, gabapentin, oxcarbazepine, and pregabalin. These are pertaining to pregnancy and lactation. And coming to other adverse events of anti-seizure medication, this is very important to know because though we have a list of medications which can be started, we have to consider the adverse events and patient's individual profile to keep him on the right drug. Asian individuals with HLA-B 1502 have got serious skin reactions with drugs like carbamazepine. We all know carbamazepine. In addition to carbamazepine, phenytoin, oxcarbazepine, and even lamotrigine can cause such serious skin reactions. In European or Japanese ancestry, HLA-A 3101 can cause serious skin reactions when given drugs like carbamazepine. Other side effects of carbamazepine includes bone marrow suppression, hepatotoxicity, and Stephen-Johnson syndrome. Even lamotrigine, we all know it can cause Stephen-Johnson syndrome. Levetiracetam, one of the most commonly used drugs, can cause some psychiatric symptoms like irritability, anxiety, and others. And rarely this can also cause bone marrow suppression. Phenytoin, in addition to serious skin reactions and pregnancy-related major congenital malformations, it can there is a phenomenon called acute phenytoin toxicity, where there can be dizziness, diplopia, or attack symptoms. And phenytoin is associated with cosmetic side effects like hirsutism, coarsening of the facial features, gingival hypertrophy, and it is obviously teratogenic. And valproic acid, again, it can cause bone marrow suppression. Again, it is hepatotoxic. Hyperandrogenism is another side effect of valproic acid, because this is very important because in women, most of the time, though generalized tonic-clonic seizures are common, we have to avoid valproic acid in them. because of these side effects, teratogenicity and hyperandrogenism, weight gain and hyperammonemia are other side effects. Coming to topiramate, it can cause glaucoma, renal stones, and again it is teratogenic. Ethosuximide can cause bone marrow suppression and skin rashes. Lacosamide can cause PR interval prolongation and even heart block it can cause. Coming to a few drug interactions which I would like to mention. One drug with no such evident drug-to-drug interaction is levetiracetam, valproic acid, and lamotrigine. Valproic acid inhibits lamotrigine metabolism and results in a substantially prolonged off-life. In addition, many drugs which we mentioned earlier are enzyme inducers. So there can be interactions with the oral contraceptives if the patient is on, and many such drugs. So these are commonly used dosages of anti-seizure medications. Valproic acid, 750 to 2000 mg per day, BID or QID can be given. So the values which I mentioned within the bracket is the optimal serum level of these drugs. And levetiracetam, 1000 to 3000 mg per day, BID can be given. Lamotrigine, 150 to 500 mg per day, BID. Carbamazepine, 600 to 1800 mg BID. Topiramate, 200 to 400 mg per day, BID. Lacosamide, 200 to 400 mg per day, BID. And ethosuximide, 750 to 1250 mg per BID. Some additional properties of anti-seizure medications. Lamotrigine is also a mood stabilizer. So coming to treatment of absence seizures, again, in absence seizures, we have a list of drugs which we should avoid. So the first line drug which is well studied for absence seizure is ethosuximide. As a second line or add-on, we can have sodium valproate. As third line drug, we have lamotrigine and levetiracetam. Because absence seizure can coexist with other seizure types, if the patient is having absence seizure with coexisting with other seizure type, then sodium valproate becomes the first line drug, and the second line drug or if the patient is a woman of childbearing age group, then sodium valproate obviously cannot be chosen as the first line drug, and we should go with the lamotrigine or levetiracetam. Coming to treatment of myoclonic seizure, again sodium valproate is the first line drug. For second line or a first line drug in women with childbearing age group, again levetiracetam can be used. I want to mention another important slide that many studies are not available to assess the effectiveness of monotherapy or to propose a single drug as first line therapy for many of the seizure subtypes. So because seizures like myoclonic seizures, atonic, tonic seizures all come under generalized onset seizures. So the same drug which are used like sodium valproate, levetiracetam, and lamotrigine, they propose as the first and second line drugs. So it is easier to remember. Again, for atonic and tonic closure, the concept is the same. Now coming to some complex syndromes like Dravet syndrome, again here because it is the prevalence is generally it is rare. So again, sodium valproate comes as the first line drug. In a second line drug, they have tried stiripentol. Again, there is no recommendations as to which drug as monotherapy or first line drug is effective. Some other drugs, because most of these drugs are drug refractory, there are some evidences with drugs like clobazam, rufinamide, and topiramate. As I said, most of these genetic symptoms are associated with channelopathies. Ketogenic diet can be tried, and newer modalities like cannabidiol can be used. Potassium bromide can be tried. Treatment of Lennox-Gastaut syndrome. Again, sodium valproate is the first line and lamotrigine is the second line. Other options which can be tried are similar to Dravet syndrome, like clobazam, rufinamide, topiramate, cannabidiol, ketogenic diet, and felbamate can also be tried. There are a subset of seizures which are idiopathic. We don't know the exact cause. Again, they propose to treat them like generalized seizures. So sodium valproate again becomes the first line. We have lamotrigine, levetiracetam as the second line. In third line, you can go with the newer drugs like topiramate and perampanel. There are certain terminologies you have to know. Drug-resistant epilepsy. This is defined as failure of adequate rise of two tolerated and appropriately chosen and used anti-seizure medications. If it fails to control our treatment goal, then it is considered as treatment drug-resistant epilepsy. And we have a provoked and unprovoked seizure. Unprovoked seizure, we don't have any particular event that we can tell as a provoking factor. That is a seizure that is not caused by a particular event such as fever, head injury, or consumption of alcohol or drugs. And we have a terminology called unsuccessful treatment. That is, the treatment is unsuccessful if it does not reduce or stop the seizures, or if the side effects are intolerable for the person with epilepsy, then we consider them as unsuccessfully treated patient. So once we have started the patient on anti-seizure medications, we have to monitor and review them frequently. And the monitoring should be more often for patients with learning disability, drug-resistant epilepsy, and there is a concept called SUDEP, that is sudden unexpected death in epilepsy. If there is high risk for that, we have to frequently monitor them. And if they are having serious other comorbidities like complex psychosocial, cognitive, or mental health problems, and who are taking anti medication for a long term, you have to monitor for side effects or drug interactions. And especially women of childbearing age group, we should be careful if they are planning for pregnancy. Monitoring should be frequent, or if they are taking valproate prior or any other high risk teratogenic anti medication, we have to change the regimen accordingly prior to that consumption. So when do we monitor the drug level of anti-seizure medications? If the seizure is uncontrolled, or if you feel patient presents with the side effects of the medications, or if the patient is going to have a special condition like pregnancy, or if the patient is having renal failure, which needs a special close supervision, then we can go for drug level monitoring. And if you feel there is poor adherence to medication, again we can test the drug level. So if a patient is planning, a woman of childbearing age group is planning pregnancy, and the pre-conceptional drug level should be noted, and adjustment should be made according during pregnancy and after 3 to 4 days after childbirth, should be brought back to the pre-conception level. So that is what they say. Is the serum protein levels, like end stage liver disease or renal dysfunction. Again, we have to be careful. Though the levels may be normal, they may still be subtherapeutic. So the dose should be changed only when the seizure remains controlled. So not just to achieve the therapeutic level. So discontinuing anti-seizure medications. So we have started, we are frequently monitoring, the patient is doing good. So when do they suggest discontinuing anti-seizure medication is at least 2 years if the patient has been seizure free. Again, this should be carried out on individual basis. We have to assess the risk for seizure recurrence if we stop the drug, and we should take a comprehensive decision. Again, stopping the medication should be taking place over a period of at least 3 months. For drugs which can have a withdrawal symptoms, for example, benzodiazepine barbiturates, this tapering should be even longer than 3 months to reduce the risk of drug-related withdrawal symptoms. For people with epilepsy taking multiple anti-seizure medications, again, that will be difficult. We have to discontinue one drug at a time. So this will take more time. If during de-escalation, if the seizure recurs, then we have to go back to the last dose whichever patient is getting. So role of surgery in seizures. For temporal lobe epilepsy, a resection of the anteromedial temporal lobe, that is temporal lobectomy, or a more limited removal of the underlying hippocampus and amygdala, which we call amygdalo-hippocampectomy, can be tried, which may this has done wonders in some patients who have been refractory through medical treatment, and this surgeries can have a important role in them. For extratemporal lesions like focal neocortical resections with precise removal of an identified lesion, if a lesion is present, can be tried. Again, if the lesion is a non-resectable, multiple subplial transaction which can disrupt the intracortical connections can be tried. For seizures due to hemispheric abnormality, for example, hemimegalencephaly or other dysplastic abnormalities, hemispherectomy or multilobar resection or corpus callosectomy can be tried. But again, this comes with its morbidity. So pre-surgical evaluation, MRA with routine scalp or scalp sphenoidal recordings should be done. Some other adjuvant tests like PET or MEC can be tried. Invasive electrophysiological monitoring such as implanted depth or subdural electrodes are sometimes required in these patients before undergoing surgery. Cortical mapping of the at the time of surgical procedure allows for a tailored resection. We have seen many patients like awake surgeries happening. All these are conceptual. If the region to be resected is within or near brain region suspected of having some sensory motor or language functions which are crucial for daily day-to-day living, electrical cortical stimulation mapping can be performed on the awake patients to determine the function of the cortical regions in order to avoid such regions, thereby minimizing the post-surgical deficits. There are some catheter-based stereotactic laser thermal ablations that have been recently developed. If the lesion or if it is not that the lesion is not amenable to surgery, we have some palliative options like responsive neurostimulation, thalamic deep brain stimulation, vagus nerve stimulations. Shall I proceed with the status epilepticus? Sir?
So anybody doesn't have any other Android only you have to tell me, then I have to arrange Android phone for you.
Aravind, able to hear me?
Hi, sir.
I think 3 minutes is more. Maybe in the next session we can start status of the figures.
Okay, sir.
Okay, I'll close
We'll
and
close the session
yeah,
for now.
I'll close and I'll send the next.
Okay, sir. Okay.
Positive findings 2 or 3 or 4 positive findings to give 2 marks or 8 marks. 8 positive findings for 2 marks.